Good morning, everyone. I'm Diane Perez, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Comorbidities Associated with the Opioid Epidemic. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 10 business days. To access the recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within that same time frame. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 10 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Tuesday, April 2nd. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certification of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And now, I would like to introduce Dr. Raymond Pomm. Dr. Pomm is board certified in psychiatry, addiction psychiatry, and addiction medicine. He is also certified medical review officer. Dr. Pomm served on the Governor's Commission on Mental Health and Substance Abuse. In 1992, he began working for the Impaired Professionals Program of the state of Florida. The Professionals Resource Program from 1998 until 2011, he served as medical director for this organization. PRN serves 29 healthcare boards and councils on matters relating to healthcare professionals' impairment. Also, from 1994 until 2010, Dr. Pomm was an expert consultant to the Florida Board of Bar Examiners. He served as medical director for River Region Human Services from 1994 until 2017. Dr. Pomm serves as Chief Medical Officer for Gateway Community Services in Jacksonville, Florida. He is a courtesy assistant professor in the College of Pharmacy and Pharmaceutical Sciences at Florida Agricultural and Mechanical University. In addition, he holds an appointment as courtesy associate professor in the Department of Psychiatry at the University of Florida. He has been a leader in the addiction field as it relates to the evaluation and treatment of co-occurring disorders and management of impaired professionals. He, most recently, was the author for Project Save Lives, as funded by the Jacksonville City Council. Dr. Pomm has received multiple rewards, including the Marie Award from the American Association for the Treatment of Opioid Dependence. He is an international speaker and has written multiple publications on issues surrounding addiction, as well as healthcare professional impairment. And now, I would like to welcome our presenter, Dr. Pomm. I will turn the presentation over to you.
Hi, good morning, everyone. Thank you for joining me. Just want to give you a heads up. There are a lot of slides that you'll see that are related to this presentation. We are not going to get through every word on every slide, and don't worry about it. They're there for your information, for a resource for you moving into the future. I wanted to get the information in front of you so you had that, not necessarily covering it all today. With that being said, let's go ahead and move on. And let me move into here. So the learning objectives. As a result of participating in this webinar, participants will become familiar with the latest data and history regarding the opioid epidemic, establish a knowledge base as it pertains to substance use disorders and the complexities found with the interrelated common mental health disorders, have an improved understanding of the most important components of a comprehensive co-occurring evaluation. It's interesting that I just got to say, it was back in 1994 that I began talking about this in terms of comorbidity and substance use disorders. And finally, everyone's getting on the same page, and I hope all the organizations and professionals in attendance are looking at the big picture when it comes to evaluating substance use disorders and or mental health disorders, because there certainly is an overlap. In fact, the overlap, because of that overlap, drugs of abuse can cause symptoms that mimic most forms of mental health disorders, and that's what this is all about. Please do not get stuck in this mode, which came first, the chicken or the egg. The reality is, when it comes to DSM-5 that we're in now, and I assume most of you have been through DSM-4, and maybe, like me, some have been through DSM-3. I'll have to tell you, I started, my first year of training was DSM-2, and that was probably a quarter-inch thick. So we certainly have come a long way. Bottom line is, if they meet the criteria for a disorder, you have to give them the diagnosis. All right, so please be sure. Now, therapeutically, it is very important to understand the dynamics under which they grew up, the etiological factors, biological conditions, all those are important. But if they meet the diagnosis via DSM-5, meet the disorder via DSM-5, please give them the diagnosis. Gee, I wonder where he picked up this behavior. Well, that has something to do with this also. And again, those are therapeutic considerations. Certainly, one should be looking at some of the etiological factors as it relates to substance use and or any behavioral disturbances that are manifest. And that's part of what one does as actually as part of relapse prevention, understanding where they came from, trying to figure out how to cope better with life than the way one has been living life prior to the manifestation of this disorder, which obviously set the stage for the disorder to become evident. So keep that in mind. But again, if they meet the criteria, please give them the diagnosis. Something just popped up, and I don't know what that is, so I'll just ignore it. There is no criteria for the social use of drugs or alcohol. It just is what it is. There's a lot of it going around, but if they don't meet the criteria, obviously you're not going to give them the diagnosis. Now, that being said, some of the drugs being used, and we're going to talk about this quite a bit, obviously alcohol, tobacco, marijuana, inhalants, cocaine, stimulants, K2 and spice, which is, that's evolved considerably. Initially when K2 or spice came on the market, it was a purified chemically similar drug to marijuana, delta-9 tetrahydrocannabinol. It was sprayed on whatever leaves they were using at the time. And unfortunately, what's happened is this particular drug has really changed. They've been trying to avoid capture via the legal system, and by doing that, what's ended up happening is they keep changing the molecular structure. So the similarities are less and less, the potency is greater and greater. And let me just say this, the chances of psychosis popping up with the use of these drugs has become of huge concern psychosis, agitation, elevated blood pressure, a whole host of symptoms by the use of this drug, which is still very available. Of course, club drugs we're not going to talk about today, hallucinogens, opioids, and kratom. And let me just say this, kratom is an opioid. It's very weak. You'll see the function of opioids on the neurophysiological level, which we'll talk about in a little while. But don't let this fool you. Kratom actually is an opioid. We don't know, there's no quality control with kratom, so you don't always know what you're getting. And from my experience treating people with kratom, the withdrawal symptoms can last a very, very long period of time. And there's actually recent research which yields some hope that buprenorphine can actually help with the treatment of kratom. Of course, sedative hypnotics, which we'll talk about in a little while. We will not be talking about sports drugs today, i.e. steroids, and then bath salts and flocka, which are continuing to be a problem throughout the country. All right, so let's get really started now. Opiates, you know, up through DSM-4 TR, they were used interchangeably to some extent. Opiates was a term that was being used to describe the naturally occurring morphine kind of based opiates, and opioids was being used to describe the synthetic and semi-synthetic like methadone, fentanyl, etc. Nowadays, what DSM-5 has done has consolidated the term into just opioids that covers all the drugs in this class of drugs. So I want to get through the historical perspective just to lay the foundation. I'm going to get through this pretty quickly. Again, you have the information in front of you, and please just follow along, or you can go back and review this later in the luxury of your own home or your workplace. So the hypodermic needle in morphine was actually first used in the Civil War, moving very quickly up to 1914, where the Harrison Act was enacted. Now, this is interesting. So opioids or morphine was being used on a regular basis for all sorts of reasons. And the U.S. government, in their huge knowledge base and wisdom, decided to place a tax on this. Somehow, this act, which was a tax-based act, ended up being the premise by which it became a controlled substance. And basically, cocaine and morphine-related substances had to be prescribed for certain conditions. Otherwise, physicians, the prescribers, could get in trouble. And this hope was also hopefully going to decrease the trafficking and crime associated with opioids and cocaine. But as you can see, that wasn't extremely effective. In 1974, we find the first methadone maintenance program for opioid addiction. Normally, I like doing this interactively. I usually ask the question, do y'all know where methadone first was developed? And actually, we don't have that opportunity today, so I'm just going to say it. In the 1930s, this was developed in Germany under the Hitler regime. In 2000, Data 2000 was office-based treatment of opioid dependence became enacted. This is where buprenorphine, and we'll be talking about this a little later, actually started to show up as being able to be utilized in primary care physician offices and various other office-based treatments. This has been a tremendously huge success when it comes to the treatment of opioid dependence, opioid use disorders. In 1971, I didn't really know this until I was doing research regarding this. I did not know that the DEA was actually created under President Nixon, which I found very interesting. In 1984, Nancy Reagan launched her Just Say No campaign. Well, that didn't seem to work very well. Of course, when it comes to substance abuse, which we'll talk about in just a minute, as opposed to substance use disorders, substance abuse does respond to saying no. But once our brain has been taken over by this disease, saying no is really not very effective. There are a lot more interventions that have to take place, and lifestyle changes, and the entire cadre of treatment options that an individual has to incorporate into their lives and be willing to in order for saying no to work. In 1989, which is interesting, George H.W. Bush presented a national drug control strategy that included the largest budget increase in U.S. history. Most of this was through seizure of drugs, imprisonment, and, well, that didn't go very well either. In 1995, and this is really just the prequel to the beginning of the opioid epidemic, which I must say I have to differentiate from the present opioid epidemic. This was the beginning of the pill opioid epidemic. We're now seeing a whole different animal than just the pill opioid epidemic. In 1999, OxyContin really hit the ground running. And I just want to bring you up to date very quickly. This is the first time in the history of the pharmaceutical company that I know of where the family that was behind Purdue Pharma is actually now being sued for all the deaths. And I think there are something like 600 different organizations, cities, counties, et cetera, that are joining in this class action suit against the actual family. More to be revealed on that as we're watching that go along. Interesting, also in 1999, when we began with the pill opioid epidemic, it first began with OxyContin. When that started being clamped down on, what happened to oxycodone actually started becoming more evident. And then when that hit the media and the legal system, and we got to stop that, they started prescribing methadone, and then that hit the system again, being the primary drug of choice being found amongst those that are abusing. By the way, that methadone was the pill form of methadone being prescribed by the pain doctors, not the methadone that is being dispensed through methadone clinics. And when they clamped down on that, then it was back to oxycodone, and it's like, what were we chasing, right? It's the disease, and that's what we need to get to. All right, in 2010, Florida became the pill mill capital of the U.S. Florida had 900 unregulated pain clinics at that time. 90 of the top 110 oxycodone prescribing docs were in Florida. Of the top 50 dispensing clinics in the U.S., 49 were in Florida. This is actually, with the states around us having a database for controlled substances, with Florida not having it, we became the OxyContin Express, where people were being busted into Florida to get their prescriptions. In 2011, 10 people per day were dying of opioid overdoses. Finally, after 10 years of begging and pleading the state to do this, eForce, which is our database for controlled substances, began operation. And we also, through the boards of medicine, osteopathic medicine, and pharmacy, they developed a pain rule. So we finally started doing something about it. Unfortunately, after 5 years, only 23.7% were utilizing eForce. And then let me back up. That was just an aside. In 2013, fentanyl finally arrives, which we'll talk about in more length soon. In 2014, that's when the current opioid epidemic began to appear. So what happened was, from the pill opioids, we slowly, or very rapidly actually, moved into the current opioid epidemic, which is being driven by fentanyl. And again, we'll get into that in a minute. Finally, in 2018, July 1st, House Bill 21 was enacted in the state of Florida, which actually made it mandatory for prescribers who were prescribing controlled substances to utilize eForce. We're talking 100% of prescribers are being mandated to do that. If not, their license can be acted upon. There are other rules pertaining to the prescribing of pill opioids. I was actually presenting in front of a Senate subcommittee, and I did applaud them for House Bill 21, but did also tell them actually it's probably that this is something that should have been brought forward in 1999 or the early 2000s, because that's when the pill opioid epidemic started. This does speak to the pill opioid epidemic, but falls way short when it comes to the present opioid epidemic, which is fentanyl driven. Now, I want to understand the pill opioid epidemic is still there, but that's not what's killing the vast number of people that we're seeing today. JACO, back in the late 1990s, early 2000s, said, people should leave the doctor's offices pain-free. They created this pain scale, and JACO was a big push to making sure people got enough opioids, and I have to say they were behind a lot of what we were seeing with the pill opioid epidemic. Unfortunately, with the present opioid epidemic, they have been very quiet, and I'm not sure what's going on there. They were pushing for education for pain control, but we're not hearing anything from them when it comes to pushing for education about what's going on today. All right, let's get into probably everyone's favorite, right? A little bit of data. Okay. Now, in 1999, there were 4,030 opioid-related deaths. In 2010, there were 16,665. But the U.S. population only increased by less than 10%. During this time, interestingly, despite all these deaths, the pharmaceutical company was developing an acetaminophen Tylenol-free hydrocodone. Now, understand hydrocodone, as you all know, is an opioid. It was being highly abused. What was happening, not in a large scale, but if you took an overdose of hydrocodone, you could die from liver failure. And in their infinite wisdom, they thought, well, let's go ahead and make a new type of hydrocodone without acetaminophen so people wouldn't be prone to dying from liver failure. And sure enough, during the height of this epidemic, they made Hydro and Hysingla, and I really don't understand. But more people were dying from taking the actual hydrocodone. It wasn't so much the liver failure, but I don't have much of a say in that. Since 1999, 300% increase in sale of opioids in the U.S. In 2008, there was a surge in deaths from opioids, 14,800 more than for heroin and cocaine combined. 2009, 475,000 emergency department visits for adverse events related to misuse of opioids. That's doubling in 5 years. Mixing of drugs was found in half the prescription opioid-related deaths, which most commonly you found Xanax. Past year, heroin use, this is from 2007 to 2012, went from 373,000 to 669,000. I hope I'm getting the point across in terms of how bad this epidemic is. 2013 to 2014, the number of drug products obtained by law enforcement that tested positive for fentanyl increased by 426%. And synthetic opioid-involved overdose deaths, excluding methadone, increased by 79%. In March, October 2015, the DEA and CDC respectively issued nationwide alerts identifying illicitly manufactured fentanyl. These are drugs that are similar to fentanyl as a threat to public health and safety. They were being mixed in unknown concentrations with heroin, and which we'll talk about in just a little while. In the fourth quarter of 2016, the DEA laboratory system interestingly noted a decrease in fentanyl seized. However, there was an increase in furanol fentanyl. That's one of those analogs, one of those IMFs. And actually, people in the Midwest, just a couple of years ago, as they were finding the increase, were not responding to Narcan, the reversing agent, and they were dying. Now, there have been 9 other IMFs, and I'll give you an example. Carfentanil is one of those. 2 police officers that I know of in the state of Florida have died just from either a touching of the carfentanil or opening up a drawer where they might have gotten a little smell of carfentanil and they died. This is how potent it is. There is an IMF that has not hit the states yet, and I hope it doesn't, to tell you the strength of this. 1 ounce would kill 250 million people. This is really, really scary. In this current generation's AIDS crisis, is this the current generation's AIDS crisis? In 2015, 52,000 people died of drug overdoses. The peak year for AIDS-related deaths was 51,000 in 1995. So we're way beyond that. And there's no end in sight. According to STAT, which it's not really an acronym, it's the name of a resource I utilize online. It brings a lot of the data that's being collected from hospitals, pharmaceutical industries, as well as drug treatment facilities, and bring it all together, which is really a pretty cool site. Back at that point, when I looked this up, there were almost 100 deaths a day from opioids. With the worst case scenario, the toll could spike 250 deaths a day due to fentanyl and its IMFs. But let's get to now. The epidemic will continue, according to the AMA, epidemic will continue to grow through 2025. The U.S. could see a record number of deaths, up to 200,000 individuals per year. And according to the CDC, in 2016, there were 63,632 deaths. 2017, there were 70,237 deaths. And very quickly, let's look into Florida. In 2016, the opioid prescription rate was 75 per 100 people in Florida. There were 5,725 opioid-related deaths in Florida in 2016, an increase of 35% from the prior year. And in 2017, it increased another 8%. 17 people died per day in Florida during that year. Of those deaths in 2017, heroin increased by 1%, fentanyl increased by 25%, and fentanyl analogs increased by 65%. So I think I'm painting a pretty bad picture, and that was my intent because it is a real picture. We used to say there were approximately 2.5 million Americans dependent on prescription opioid medications. We don't really know the number. The reality is the emergency department data is not accurate. Hospital data is not accurate. Morgue data is not accurate. So in the ED, to be honest with you, we're in the ED, many EDs now at this point in Jacksonville. And when we come in, the first thing we have to talk with the ED about is their coding. They don't code things as overdoses necessarily. It might be respiratory failure, might be some cardiovascular condition, but the triggering event was an overdose, which you wouldn't know from that data. Hospital data very similar, and morgue data. The vast majority of people do not have an actual ME's report associated with deaths. They don't actually evaluate every death that comes through the morgue. So it is far worse than we actually even know. And according to the CDC, there are now, today, 130 deaths per day in the U.S. And according to Jacksonville Fire and Rescue Department, which is my local data, 2 deaths per day in Duval County. And I'm sure other counties in the state of Florida are very similar, which is really, really unfortunate. And again, very, very scary. Okay, let's get into the actual neurophysiology of opioids as we move into the comorbidities. The action of opioids in our brain begin with the attachment of the actual drug to a receptor in the brain, and we'll get into this in some depth. There are 4 different opioid receptors. The most important one, which we'll talk about, are the mu receptors. There are also kappa receptors, sigma receptors, and delta receptors. To be honest with you, sigma and delta, we're just finding out more about them now. We know the most about mu and a little bit about kappa. So, whoops, pushed the wrong button. The mu receptor drugs, those drugs that attach to the mu receptor, which start that whole cascade of events leading to getting high and dependence. Those are all the opioids you know: morphine, methadone, hydromorphone, codeine, fentanyl, heroin. I'm not going to talk about LAM, buprenorphine, oxycodone, hydrocodone. Just very briefly, just since it was there, I really should have taken it up. But LAM was hopefully something similar to methadone, which only had to be dosed every other day. Unfortunately, it was extremely cardiotoxic and was pulled off the market. So what happens when an opioid hooks up with a mu receptor and has full effect, meaning that once it hooks up, it has the full impact of the drug's effect on that receptor, and then the full physiological effect of that drug, and that's called a full mu agonist, okay? Highly reinforcing. Those are the most abused drugs, and of course they include the drugs you know: heroin, methadone, oxycodone, fentanyl, et cetera, et cetera. Then we have a partial mu agonist. What that is the drug hooks up to the receptor and only has a partial effect. It's a less reinforcing drug. It has a maximal effect. The one that we really talk about is buprenorphine, far less abused. Anything over a certain dosage doesn't have any effect at all. The reality is with buprenorphine, at 16 milligrams, 97% of the mu receptors are covered. It's a very potent drug. It kicks off any opioid, most opioids that are on the receptor, replaces it with less activity, which I'll show you a graph on in just a minute. And then the antagonist. Now, the antagonist at the mu receptor will kick off the agonist, the partial agonist or the full agonist, and have no action. So it will immediately put someone in withdrawal if there are opioids on that receptor. And that's what they use, like naloxone. You've all probably heard now of intranasal naloxone. There is an epidermal kind of injectable naloxone. And then, of course, in the emergency department, they'll start actually a naloxone drip, because naloxone doesn't hang out for very long. And a few minutes after it's been given, it pretty much goes away, and whatever opiates are available come right back on the receptor. So sometimes they have to keep that going until the opioids are gone. And of course, now we have, there is naltrexone, a by mouth version of the antagonist. Unfortunately, when it first came out, even though it's very effective, people had to take it for it to work in terms of blocking the effect of opioids. So if you have enough naltrexone in your system, it will block the effect of any opioids that you take. You can override it, however, and if you do, you're going to die probably. Now then, because of that compliance issue, they developed Vivitrol, which I'm sure you're all familiar with. And Vivitrol is a monthly injection of naltrexone and keeps a nice blood level throughout that month, reduces the cravings for opioids, and also blocks opioids from having any action on the receptor. However, again, that also can be overridden if you tried, but by the time you got enough in your system of opioid to override it, more than likely you will probably die. This is what it looks like on a graph. You can see the full agonist, which are mostly opioids you know about. Full effect, the more you take, the more you feel. Partial, the more you take, the more you feel to an extent, and then boom, no more. No more activity. And then the antagonist, you get it and there's no effect. So, all right, the centerpiece of addiction is a neurotransmitter called dopamine. What is a neurotransmitter? Let me just quickly explain. You have just tons and tons of miles of neurons which go throughout your body, and they have to coordinate and communicate with all sorts of different other neurons. And at each junction point, there's a gap. That gap's called a synapse. Well, what travels down the neuron or the nerve cell is an electrical impulse. That's how this communication continues down any one neuron. But when it hits a junction, it's got to jump over that gap to get to the other one. Well, how it does that is it turns the electrical impulse into a neurotransmitter, which then is released into that gap and hooks up with the other the receiving neuron, which then can get converted into electrical impulse. And that's what allows me to be talking, looking, hearing, knowing where I am in space, keeping my balance. Actually, I'm sitting down, but if I was walking around, all these activities, the muscular activities and everything else that are going on right now within my body are all happening by neurotransmitters, neurons communicating with each other. Now, when it comes to chemical dependence, this is the drug that we feel is the actual centerpiece of making sure that when a drug hits our system and hooks up with a receptor, in this case more likely the mu receptor, dopamine is released and allows the transmission. Let's take a look at that area of the brain I'm talking about. This is our pleasure center for the most part. You can see in this picture the ventral tegmental area, the nucleus accumbens. I'm not going to get into all, to a great extent, into the neurophysiology and neuroanatomy, but all the activity I'm talking about is right here. Ventral tegmental area actually releases dopamine, nucleus accumbens, there's some release going on there, but let's get into the actual closer image of this. So this is what a dopamine receptor looks like. So you can see, what happens is the electrical impulse comes down from above all the way down to this big bulb here at the end. Then it knows it's got to somehow jump that gap. So it creates dopamine. This is the neurotransmitter we're talking about. There are all sorts of other ones. It releases the dopamine, hooks up with the dopamine receptor. And then what happens is once it hooks up with the dopamine receptor, a whole bunch of other stuff goes on. And then it's converted into a new electrical impulse, as I mentioned before. So when it comes to opiates, now endorphins are our internal opiates. And that's probably this is the best way to look at it. Endorphins are released. They hook up with the opiate receptor. Once the opiate receptor is stimulated, it tells the neuron release dopamine. Dopamine is then released and then hooks up with the dopamine receptor. You feel high. Interestingly, our bodies are phenomenal. What happens is once it's done its job at the dopamine receptor, dopamine is then released. There's an uptake pump brought back into where it came from, broken down, and reformulated into dopamine again to be released again. Very efficient system. Now, if you look at opiates specifically, very same thing as endorphins. Again, take morphine. Morphine hooks up with the opiate receptor. Once that hooks up, then what happens is dopamine is released, and the process continues as I just stated. And again, this is the area of the brain where this is taking place. Now, I've got this in front of you so you get an idea of the drugs that are being used out there. And why do I have this? Because hydrophilic versus lipophilic, the greater a lipophilic substance is, i.e. fentanyl, the greater the chances are, or the more rapid and the more drug actually crosses the blood-brain barrier, because the blood-brain barrier is full of a lot of fatty-like substances. So fentanyl gets to the areas of the brain that we're talking about really, really quickly. Now, if you look at taking it through the mouth, it can be there within 5 to 10 minutes. Most people actually inhale it, which can occur then within a couple minutes. And then, of course, a lot of people also deliver it IV, which can occur within a matter of seconds. IV is, what we don't see a lot of right now, but we're starting to see a little more of, is the smoking of it. Smoking is actually the quickest way to get into the system, by the way. I won't get into how that happens, but it's smoking, then IV, and then intranasal. So moving on. This gives you an idea, though it's not as accurate as I'd like to see it, but finding the accurate ones is accurate charts is really difficult. But I want to give you an idea. If you look at morphine, and actually if you think about heroin and morphine being very similar, it takes, well, the duration of effect is actually upward of a couple of hours. Half-life, if you see there, is how long it takes for half the drug to leave the system is somewhere between 2 and 4 hours. So you can anticipate, if you know the half-life, how long it'll be before someone starts experiencing withdrawal symptoms. So with heroin and morphine, basically within 2 to 4 hours, they'll start experiencing withdrawal symptoms. And that's why I have this here. They say the duration of effect, now that's pain effect. The euphoric effect, or getting high effect, is much, much shorter. I brought this up here because I wanted to show you fentanyl. The reality is the half-life of fentanyl, where they say it's about 3.5 hours, it really effectively is only 1 to 2 hours. That's how quick it leaves the system, starts leaving the system. The duration of effect when you shoot IV for the getting high piece is really only 1 to 2 hours also. So very quickly it comes on board. Very quickly it has a very, very dramatic and powerful effect. And then very quickly it leaves the system. Now, the more powerful the effect and the shorter the action, the more powerfully addicting it is. This stuff just causes huge withdrawal symptoms, worse than any other of the medications listed on this list, and any of the other ones, for the most part, outside of those IMFs that we talked about. Far worse in terms of cravings, far worse in terms of withdrawal symptoms, and it just causes huge problems for the individual in terms of trying to stay away from it. They're either under the influence of it for a little while or going through intense cravings and intense withdrawal, and breaking that pattern is almost impossible without medical intervention. I wanted to show you this for one specific reason. You can see the breakdown of opioids. And when you look at the breakdown of opioids, you can see, yes, poppy seeds actually causes a positive drug screen, which we'll talk about later in terms of drug screens. But I wanted to show you this because one way to tell if they did use poppy seeds and they're using that as an excuse is, as you can see, codeine doesn't show up on it wouldn't show up on the drug screen. Only morphine shows up. Typically with poppy seeds, when I talk with people and they say, "Oh, I must have used poppy seeds," well, I give them one chance. You now know, you should have known before, and any further use of poppy seeds will not be acceptable. And we're going to treat it like you were using a drug, though you don't get off on poppy seeds, but it has become an excuse people utilize. This is on drug screening, which we'll get into later. There's much more to know about this. Bottom line is, yes, can test positive, but it's very specific. Reality is, drug screening is extremely important in determining what drugs they were using. And again, in a little while, we'll get back to that. All right, what I'm going to do now is move into the actual comorbidities, and I'm going to be going back and forth between the disorders that we will be covering, and that would be on the substance-related side versus the mental health side, and I'm going to keep merging them together as I go back and forth throughout the rest of the presentation. And by the way, in just a few minutes, we are going to take a little bit of a break. I wanted to get this sort of heavy stuff out of the way first, and then not change the flow when we actually start talking about the interrelatedness between all this. So in just a few slides, we'll be taking about a 5-minute break. But before we do that, let's get into actual DSM-5 substance-related and addictive disorders. That is the title of the category of of disorders in DSM-5. And one thing they left out in DSM-5 that I am a little upset about, I used the term substance abuse quite a bit in diagnosing individuals. This is now gone. This is my own personal feeling, but this category or diagnostic category, I found very useful because I knew they still had the ability to say no, the Nancy Reagan thing we talked about. They didn't have the dependence, but they were high risk for developing dependence. The short form of that, which is something I just created, when an individual gets into trouble due to substance use on at least 2 different occasions within a 12-month period of time. You know, DSM-5 has just, it's gone away, and it's sort of frustrating. So in my mind, I still think about this when I'm evaluating an individual and developing a treatment plan for an individual, because to me it still is very relevant. We'll get into some of the DSM-5 other issues in just a minute. I hope they bring it back at some point, but I don't have any influence on this. Of course, once they cross that boundary and they now are chemically dependent or have a substance use disorder, this is what it looks like. Your bottle or your life. Well, I'm thinking about it. Yes, it is overtaken. There is no choice. Saying no doesn't work. Their lives are being run physiologically, emotionally, psychologically, every level that you can think of. They are now being run and driven by the substances that they are addicted to. You all probably are very familiar with the DSM-5 criteria for substance use disorders. So I'm not going to go over them in any detail. They're there. You have the DSM-5, I'm sure, available. If not, you have the slide available. And the bottom line is there needs to be at least 2 of the 11 that you see in front of you occurring within a 12-month period of time that causes significant impairment or distress before you can get the diagnosis. Please remember, causes significant impairment or distress. All right? The reality is, people who are being treated for pain, let's say terminally ill people who are being given medication, might have tolerance, might have withdrawal, but it's something they need, and they're not meeting the criteria for a substance use disorder because they're not in distress or having impairment issues, well, distress mostly, or impairment issues because of the use of drugs. They are chemically dependent for sure, but they're not what we would call addicts or alcoholics or suffering with substance use disorder. Now, DSM-5 combined the abuse and dependence criteria under this heading from DSM-4 to now. They have changed, DSM-5 changed a few things. Early remission used to start, early remission used to start after 30 days in DSM-4. It now starts after 3 months. So if you give a diagnosis of substance use disorder and they have been clean for 89 days, you do not give them early remission. Okay? It is just, let's say, opioid use disorder, period. At 3 months, you can now utilize early remission as a specifier. Up to 12 months, and then after 12 months, it's called sustained remission. Now, I want to just say this, that if someone, this is really sort of interesting, took me a while to wrap my brain around it, very different than in actual recovery than actual recovery terms. If they use somewhere, once they've hit early remission or sustained remission, if they use, even though in recovery we call it a relapse, according to DSM-5, they have to have met one of those 11 criteria before you start the clock all over again. So if someone, let's say, was cocaine use disorder They had 13 months, which means they were in sustained remission, and they used cocaine once. According to DSM-5, you can't start the clock over again. They're still in sustained remission. I'm not here to debate that with anyone, and it is what it is. Severity is based strictly upon the number of symptoms. So mild is 2 to 3 of the criteria, moderate 4 to 5 of the criteria, severe is 6 or more of the criteria. According to ICD-9, the interesting thing is if you look back to DSM-4 and substance abuse, the mild is the same ICD-9 code for abuse as it was for abuse in DSM-4, though it doesn't really equate in reality when it comes to the criteria. And when you give the diagnosis, you actually have to give the actual specific name of the drug. So as an example, it might be opioid use disorder, but they've been using fentanyl. So you'd say fentanyl use disorder in earlier sustained remission. Now, if they're on maintenance therapy, buprenorphine or methadone, you would say on maintenance therapy. And if they're in treatment, you would say in a controlled environment, and in mild, moderate, or severe. If they're using cocaine, you'd say cocaine use disorder. If they have benzodiazepines, it would be Xanax use disorder. Don't have time to get into that to any great extent, but that gives you sort of an intro to it. These are all the areas of the brain that are affected. We're not going to get into that to any great extent today. You've got the basic gist. You can see there's the dopamine pathway, then some drugs have a serotonin pathway, which is beyond the scope of this lecture. And you can see where in that area of the brain, I talked about that pleasure center, or it's called the limbic system, where, remember, ventral tegmental area, nucleus accumbens, you had that picture before. Now you can see where the different drugs have its actual impact in that area to cause that euphoria and eventual dependence. This is just different types of neurotransmitters that are found in our system that are underlying a lot of the disease of chemical dependence that we do see. Dopamine we've talked about. Endorphins I mentioned as are naturally occurring opioids, but then you get into other neurotransmitters that, again, are beyond the scope of this lecture, but you can certainly see here what drugs could be underlying the release of these neurotransmitters. So that being said, whoops, I think I just skipped over one, which was, let me just see if I can find it real quick as an introduction. Probably not going to be able to do that as effectively as I wanted to. All right, the slide that just sort of jumped over was actually titled "The Most Common Psychiatric Conditions That Can Be Confused with or be present with substance use." We're not going to get into all the different mental illnesses that are defined in DSM-5. We will cover the most common ones. And again, as I said just a little while ago, we'll be going back and forth between drugs of abuse and the mental illnesses and how they can overlap and how we're going to go ahead and tease that apart. So with that, it's about 5 minutes to 11. I think this is the time that we're going to take a 5-minute break and then get into the rest of this lecture.
Let's take a 5-minute break at this time, and we'll see you at 11 o'clock. Hello, everyone. Welcome back to today's webinar. Dr. Pomm, if you're ready, I'll turn the presentation back over to you.
Okay, thank you very much. All right, let's go ahead and get into this. I normally, again, like to have it interactive, but I'm going to have to sort of do this without that. I usually ask the audience a lot of questions during this, but I'm just going to have to give the answers. I get very frustrated in the field because certain diagnoses are being given without getting a complete history. And a lot of the diagnoses that I see coming into Gateway and actually when I was running PRN, same issue. There was just no evidence outside of substance use history to even give the diagnoses. So there's a lot of learning we have to do out there in terms of figuring out how to come up with an appropriate diagnosis. And I guess that's what we're trying to do here today. So let's just talk briefly about schizophrenia. The bottom line is in schizophrenia, yes, you have to have, for a significant portion of time during a 1 month period, one of those 5 symptoms. Delusions and hallucinations are probably the most common that we're going to see. But the fact they have delusions and hallucinations are not a reason to give the diagnosis. I can tell you, if you look at methamphetamine intoxication, cocaine intoxication, methamphetamine withdrawal, we're seeing people on methamphetamine now at alarming rates, which we'll talk about in a little while, where they have psychotic symptoms, hallucinations, and delusions for weeks at a time. Amphetamines in general can go on for quite a while after. Marijuana can cause paranoid ideation. There's so many drugs that can cause those symptoms. You can't give the diagnosis just because they have delusions and hallucinations. And so often I see people come up with a diagnosis of schizophrenia, but that's all they've had. And they've had it in the context of either active use or recent use of certain drugs. So it's very frustrating for me when I see this, because once you give this diagnosis, that's a lifelong diagnosis that has significant impact on an individual's future at so many different levels. And yet, if we treat the substance use problem, those symptoms go away. And so it's really important, and I will say this over and over again during the rest of this presentation, please don't give a diagnosis unless we're absolutely sure. Yes, they can also meet criteria B and C of this diagnosis. Even with just substance use, the disturbance can last for at least 6 months. There's actual social and occupational dysfunction. But the bottom line is, if it's being caused by the use of substances, we should not give that diagnosis. DSM-5 is really clear. DSM-4 was, DSM-3 were. All the DSMs were very clear on that. If, in fact, it's caused by the effect of drugs. Now, it does not necessarily mean the acute effects of drugs. It could be the long-term effects of drugs. So be very, very careful. Whoops, sorry. Psychotic disorder, very similar to schizophrenia. In its initial presentation, the symptoms only last for 30 days. But again, it can be very confusing because these drugs can come in, cause delusions, hallucinations. They can actually have disorganized speech. They can actually be catatonic. Back in the days with PCP, it was very catatonic. Nowadays with ketamine, they can appear very catatonic. So they can meet any of these criteria. And it could go away very quickly. It does not mean they have this diagnosis. Again, please, it does not mean it. If there's been substances involved. Schizoaffective disorder, something very important to look at with this. To briefly say what this is, you basically have, if substances aren't around, not part of the etiology of this. So what you have is an individual who has a mood disorder, depression or bipolar, and it's going along as depression and or bipolar would go along in terms of its natural course. But you also have a psychotic disorder. You meet the criteria, at least criteria A, which is those delusions, hallucinations, catatonic, disorganized speech, those criteria. You meet at least one of those criteria. So what happens is you have two separate disorders that are going on at the same time. Sometimes they're connected to each other, sometimes they overlap each other, and sometimes you have one without the other. That's schizoaffective disorder, okay? As opposed to something like major depression with psychotic features, the psychosis only occurs during the depression, or bipolar with psychotic features, the psychosis only occurs during the mania or the depression part of bipolar disorder. And that, whereas with schizoaffective disorder, you could have a depression going along and the psychosis going on at the same time, but as the depression gets better, the psychosis is still there. I hope that's clear. Normally I like to see head nods, but I'm going to trust that that made some level of sense. And again, substances, we'll talk about this in a minute, but cocaine can look just like that. You can have psychotic symptoms going on at the same time. You've got people becoming euphoric, almost manic-like, alternating with depression-like states, all because of the cocaine. But that's not schizoaffective disorder, and it's really important to distinguish. Getting into mood disorders, what we're looking at is either depressive disorders or bipolar disorders. And when it comes to depressive disorders, looking a little more closely into major depressive disorder, I would assume most people on this webinar are very familiar with major depressive disorder. It has to have gone on for 5 criteria have to have been evident for at least a 2-week period of time. And it can be recurrent. One of the things that DSM-5 did was they no longer have chronic major depression. They have major depressive disorder recurrent, but not chronic. It gets a little confusing, a little beyond the scope of this webinar. We will touch it when we get to persistent depressive disorder. When it comes to the differentiation between major depressive disorder and some of the substances, and again, like I said, we're going to go back and forth. You're going to hear this over and over again in different contexts. Bottom line is, long-term benzodiazepine use can look like major depressive disorder. Cocaine, on its downside, on its withdrawal side, could look like a major depressive disorder for a significant period of time, actually up to 2 years. Sometimes it's a little difficult to differentiate major depressive disorder from a cocaine withdrawal. To be honest with you, with cocaine withdrawal, I do treat the depression because that depression can sometimes lead an individual back to relapse very quickly. I don't want them to suffer, and actually antidepressants do work for those symptoms. So this gives you an idea of that interplay where I'm still going to treat both at the same time. There are specifiers associated with major depression, partial or full remission. Basically, full remission is they have no symptoms left. Partial, they have some symptoms left. When it comes to mild, moderate, severe, the best way I can conceptualize this when it comes to most of these disorders, but we'll talk about major depression because that's what's up there now. So if you look at severe, an individual can't function. That's my definition of severe. They can't function. If you look at mild, they can function relatively well, pushing through it, and moderate falls in between. So it's, I think, important to understand that when you're differentiating it. I don't see as many severe major depressive episodes, though certainly I've seen quite a few in my life, but if people are functioning with major depression, that would probably fall more into the mild or moderate category of a major depression when it comes to its specifiers. Anxious distress, other specifiers, anxious distress. Again, you could be using a lot of substances, cocaine as an example. They're very anxious looking, very distressed looking. Methamphetamine, same thing, while in the context of what looks to be a major depressive episode. Again, if the drugs are involved, we're not going to give that diagnosis. But let me clear it up though. Anxiety related to major depression in this context is the anxiety gets worse with the major depression. It's not an independent diagnosis. That's when you would give anxious distress. Worse depression, feeling awful anxious. Less depression, not so much. And the anxiety is not there when the depression isn't there. So if the anxiety is there when the depression is there, and only when the depression is there and it gets worse, when the depression gets worse, then it would be anxious distress. Mixed features, that gets into more bipolar, which we won't talk about right now. I don't have time to get into all these. Mood congruent and incongruent psychotic features. Bottom line is, be careful. If psychosis, which would be, in this case, probably hallucinations or delusions, occur only in the context of the depression, that's where this fits in. Now, understand a lot of substances could be used where you're going to have the psychotic features along with the depression. You wouldn't be giving the diagnosis. Peripartum onset. We have found that at least 50% of depressive disorders occur during pregnancy. It used to be postpartum onset, but when we realize that, we now call it peripartum onset, which can go on well beyond the delivery date. Again, I'm not going to be able to go into absolutely every part of this. Persistent depressive disorder, very important and somewhat confusing for folks. They actually state represents a consolidation of DSM-4 defined chronic major depressive disorder and dysthymic disorder. I got some issues with that. Bottom line is, this is a long-standing milder depression that looked like dysthymic disorder, where you have the following symptoms, which you see in front of you. Much less severe usually than major depression, but it goes on for at least 2 years more often than not. Okay? Now, given that, it's very important to understand that you can have that picture and you can have major depressive episodes within that picture. So you've had this dysthymic pattern of depression that's gone on for at least 2 years, which gets worse at times. Worse to the point they actually meet the criteria for major depression. You don't give a separate diagnosis of major depression in that context. You actually say persistent depressive disorder with intermittent major depressive episodes. And if there is a current episode of major depression, you'd say with current episode. Now, sometimes you have a long history of persistent depressive disorder, and then you have at least 2 years of a major depressive episode, which would be called persistent depressive disorder with persistent major depressive episode. Gets really sort of a little confusing. And sometimes this is where I differentiate, which I have a little difference with DSM-5 and concern, where they talk about chronic major depression as part of this. In reality, if they just have never had major depressive episode, but just that mild depression for at least 2 years, it's called pure dysthymic syndrome. It had nothing to do with major depression. So be careful with that very first slide I showed under persistent depressive disorder in red. You need to look at the specifiers. And sometimes an individual can have a persistent depressive disorder that's been a long-standing nature, but prior to that, they had had a major depressive disorder prior to even the PDD. Well, then you'd give the 2 different diagnoses. Yes, it gets a little confusing, but again, here it's much more common. Benzodiazepines, long-term benzodiazepine use can look very, very similar to PDD. And it's very important to keep that in mind. Marijuana use over a long-term basis can look the same way. So again, understand very clearly what is going on, and we'll talk about some of that. I had already mentioned this with peripartum mood disorders. Other specified depressive disorder is a very interesting term. I sort of like this because, and this just gives some examples, but the reality is any condition within DSM-5 where an individual doesn't quite meet the criteria for something, but it comes close. So here they don't quite meet the criteria for major depression or PDD, which is persistent depressive disorder. You can actually say other specified depressive disorder, does not meet criteria for PDD, or does not meet criteria for major depression, or in this case, I give you some examples you can say, colon, recurrent brief depression, or short duration depressive episodes. It's a nice, actually, category, diagnostic category, because it tells the reader what you're thinking in the diagnosis. So they're close to a diagnosis, but not quite. You can't quite give it, so now you can specify it in an actual diagnosis. As opposed to unspecified, used to be called otherwise specified. Here, you know they're depressed, but they don't come anywhere close to any of the criteria, and that's where unspecified depressive disorder comes in. All right, bipolar and related disorders. I think you're all very familiar with this. I won't get into all the criteria for a manic episode, but probably you've seen individuals like this, or certainly heard about individuals, at least 1 week of these symptoms: inflated self-esteem, grandiosity, decreased need for sleep, and I mean decreased need for sleep. People with major depression, or sometimes PDD, can't sleep, but they want to sleep. In this case, they can't sleep, and they don't necessarily want to sleep. More talkative, pressured speech, flight of ideas, highly distractible, a lot of goal-oriented activity. Understand, folks, when you get this diagnosis, you're going to find people on cocaine, amphetamines, methamphetamine, meeting all these criteria. Please be really clear. You've got to look at times when they're not using drugs to see if, in fact, they met the criteria then. Do not give this diagnosis. This is a lifelong diagnosis. And if there are drugs or alcohol related involved, even alcohol during withdrawal can look identical to this. Hypomanic episode lasting at least 4 days, very similar symptoms, much less severe though. Bipolar 1 is where you have at least one full-blown manic episode. Now, the difference between mania and hypomania, again, is severity. If they needed a hospitalization, pretty much it's full-blown manic. Again, be really careful with the substances involved. You don't actually need a major depressive episode, though most, probably 90%, will experience a major depressive episode sometime in the course of their illness. And then bipolar, bipolar 2 disorder, that's where they've had an episode sometime in the life of hypomania, and at some point a major depressive episode. They've never had a manic episode. Once they've had a manic episode, they become bipolar 1. Again, with substances of abuse, the picture looks so similar to bipolar. I can't even begin to tell you how many people come in the doors of where I work, Gateway, and have a bipolar diagnosis. There is no history of it outside of the context of substances. It's very frustrating. They've been trying on all these different medications, which can be quite toxic to the system. The reality is, if we treat the substance use disorder, they get better. They never needed those They never needed those medications. So it's really, really important, not only for that, also for insurance purposes. They've got a pre-existing condition. So I can't tell how many times I have to undo the diagnosis as opposed to give the diagnosis. Other specified, again, this is another, that, like I said before, excuse me while I take a sip of water. It's great because if they don't quite meet the criteria, you can use this and let the reader of your evaluation know that, hey, look, they have other specified bipolar and related disorder, colon. They don't quite meet the criteria. Now, in this case, they give you some examples to use, and you can say they've had hypomanic episodes without a prior major depressive episode, they don't have quite as many symptoms as they need to, et cetera, et cetera. So it's really a very useful diagnostic criteria. And unspecified is like the not otherwise specified, used to be in DSM-4. You know they're probably like sort of bipolar, but they don't come close enough to use the other specified diagnostic category. Anxiety disorders. We'll just go over a few of these. Generalized anxiety disorder, you are probably all very familiar with this. Those symptoms: restlessness, easily fatigued, decreased concentration, irritability, muscle tension. That has gone on for at least 6 months. Very difficult to control worry. Excessive anxiety, obviously, as part of this. You know what? This one is, again, something that I see not used correctly. People on benzos, okay? Now, they might have initially been given Xanax for the treatment of anxiety. Maybe, maybe not. Maybe they got off the street, were using it. And they end up at the doc and they say, hey, doc, I feel anxious all the time. Well, Xanax is a good example. Within 2 to 4 hours of taking a dose, they're going through withdrawal. And once they start going through withdrawal, the symptoms look just like an anxiety disorder. Actually, could look worse than the original anxiety disorder they were being treated for. And certainly long-term use and increased tolerance, as people use more and more of that drug, these symptoms get worse and worse. And so often misdiagnosed as anxiety, what they do, they increase the benzodiazepine, which is really the opposite of what should be happening here. And it's very frustrating. We'll talk a little bit about this later, a protracted withdrawal from benzos. Anxiety-related symptoms can occur every once in a while in a very intense way for a day or 2 or 3 as part of protracted withdrawal that can go on for 2 years with benzodiazepine dependence. Opioids, you can find a very similar protracted withdrawal. Alcohol withdrawal, you can find it. Hallucinogen use, cocaine use, amphetamine use, all these can look just like anxiety and these disorders I'm talking about. Panic attacks, which you're all probably familiar with, it's sort of like meeting a bear in the woods and how you feel. Much more prone to panic attacks coming off benzos, coming off opiates, certainly, and coming off going through withdrawal from alcohol. All right, PTSD, I strongly recommend you look at the DSM-5 criteria. There are a lot of them, but it is something that we all need to pay attention to. I would say the vast majority of folks we see with substance use disorders have PTSD, and it needs to be treated because that is one of those, we talked about chicken or egg thing. The reality is, if we don't treat the PTSD, the chances of relapse are significant. In fact, if we don't treat any of these disorders I talked about, if they are actually independent disorders not caused by the substance use, but happen to be occurring at the same time as a substance use disorder, if we don't treat the whole picture and treat everything as it needs to be treated, the chances of relapse are significant. Personality disorders, look, all I want to say is this. The only difference in behavior between an individual suffering with a substance use disorder and a personality disorder is actually the drug or the drink. The reality is people who are actively using and or in early recovery or not quite able to get a recovery program going look just like a personality disorder. So be really careful. Again, what you'll see is an individual in recovery, those behaviors that look like a personality disorder will get better in time if, in fact, it was substance related. But you got to give them the chance. Don't give them this disorder right out of the box unless you have clear evidence. And I want to really underline this. I won't get to all the words, but you'll see you need an enduring pattern. This goes back to adolescence. Enduring pattern, enduring pattern, enduring pattern. Pattern is stable of long duration. Not just the time they've been using drugs. It goes way back before. All right, again, enduring. DSM-5 makes it really clear. This was also in DSM-4 and DSM-3. Really clear. And yet people get personality disorder diagnoses all the time. Please be careful with that. Again, you've got to look at people actively using or in early recovery look very much like borderline, which won't get into all the criteria. So you have to understand what's the difference here between the disorder and the behavior. And it is, if it's substance use, it's borderline behavior. Narcissistic, same kind of thing, behavior. Says here the world revolves around the sun once a year. Revolves around the sun? Are you sure? I thought it revolved around me. Well, that's narcissistic. Yes. Antisocial. Oh my gosh, you see, antisocial behavior is rampant amongst those people suffering with a substance use disorder. Just rampant. Now, yes, for sure, antisocial personality disorders who have the actual diagnosis, 70 or greater % of them do have a substance use disorder. But if you look at the other side of that, those who are using substances have a lot of antisocial behavior, criminal activity in order to obtain the drugs, in order to get money for the drugs, just because their whole moral system is being affected by being under the influence of drugs, or their threshold for violent behavior is vastly lowered. There are all sorts of reasons that are drug-related that they look like antisocial. Now, if they really are antisocial, this is probably where they believe. And even amongst my field, there are some. The doctor actually doesn't see patients anymore, so he found out he can make a lot more money just writing the prescriptions. And yes, even if they're doctors, they probably do need to go ahead and be adjudicated in some way. All right, so I guess I've said that quite a bit. All right, let's quickly go back here, because what's happened now is we've got a hugely complicated problem in front of us. Many years ago, we came to a point where we were asking, where's the simple person with an alcohol use disorder? You know, it's really sad. Now I'm saying, where's the simple person with a heroin use disorder? And let me get into why I'm going this direction. And again, we'll be pulling back and forth between the co-occurring disorders. Yes, fentanyl is now in Xanax, and that's what's called fake Xanax. As you can see, it looks very similar, and if you take that, you die. Fentanyl is also in oxycodone, or looks like oxycodone. Again, you take that, you die. We've had lots of deaths around this country because they were taking medication that they thought was another drug, but the reality is it was actually fentanyl. It is not uncommon now, and I'm talking now, to see, which complicates the whole picture of co-occurring disorders, complicates our treatment for substance use disorder. But it's really important to look at and understand. Yes, you know, there was a time back, I would say 2017, we were testing a gateway detox. All the people who were coming into gateway detox that were positive for heroin, 100% were positive for fentanyl. Okay, that's what it was in 2017, 2018. That's how much fentanyl there was out there. Now it's showing up in all sorts of different areas, as I just mentioned. And now we're seeing positive drug screens for methamphetamine, cocaine, benzodiazepines, fentanyl, and marijuana, along with the heroin. This is really gotten scary. A lot of individuals say they don't even use fentanyl. And yet they're positive for it. They don't even know, because fentanyl's being laced in all these drugs. So they're getting the combination. We're actually seeing a huge demographic shift where 70% of cocaine now has fentanyl in it. This is scary stuff. Now we're seeing more and more methamphetamine laced with it, marijuana laced with it. This is now we're used to be the opiates were mostly a Caucasian drug, and cocaine was mostly a African American drug. Now what we're seeing is people totally naive who are African American just using cocaine. Now all of a sudden they're just dying because they didn't know they were getting fentanyl in it. So the demographic shift is pretty profound, and this sort of gives you an idea what kinds of drugs we're seeing now. This is through our ED project in Jacksonville. It's been going on for well over a year. You can start seeing what kind of drugs we're seeing. Fentanyl in 92% of the samples, cocaine in 78% of the samples, opiates in 70%. And when I say opiates, I'm talking about oxycodone for the most part, and hydrocodone. It's mostly oxycodone. If you look at this slide, it's pretty phenomenal what's going on. And I want to show something else. I don't have time to talk about gabapentin. I will not prescribe it. I usually do not approve it because gabapentin is also being abused. And we're seeing this combination. Now, I want to show something else. Interesting thing that's happened is that we're seeing somewhat somewhat of a reduction in deaths from fentanyl use. Well, I used to wonder, well, what a horrible business model. You're putting fentanyl, all these other drugs, or you're giving fentanyl out there and you're killing your customers. That's a horrible business model. Well, I guess they figured out it was a horrible business model. So what they've done now is we're seeing actually somewhat of a reduction in death. But what they've done is acetylfentanyl is one of those IMFs, those analogs similar to fentanyl, where fentanyl is 50 to 100 times more potent than heroin. Acetylfentanyl is only 5 to 20 times more potent than heroin. So what they're doing is they're diluting fentanyl. So here you have heroin being laced with fentanyl. The fentanyl now being diluted with acetylfentanyl so people don't die as readily or they're revived more easily, and they're still addicted, or the addiction is still going on with fentanyl. So they figured out how to keep people alive but keep them addicted to fentanyl. It is crazy. Now, well, we'll get into the drug screen in just a minute. You can see the opiates we're still seeing also on top of the actual fentanyl that we're seeing. Again, the vast majority of folks are already positive for fentanyl. We have a lab we work with that actually tests for the other analogs, so we get to see what other ones they're using. We don't see it on screening, which we'll talk about in just a minute. We're now seeing a significant increase, as I mentioned, amphetamine and methamphetamine, which is causing so many people to be psychotic that are coming into detox. So we're seeing a significant amount of withdrawal from opiates, withdrawal from amphetamines, withdrawal from benzodiazepines, and psychosis on top of that. That's how complicated this picture is getting. You can see now the combinations throughout this. 6-AM, by the way, as you see that, is heroin, opiates, amphetamine, THC. You can see the incidence of what we're seeing. All right, moving right along. It's when I talk about this stuff, and I talk about it quite a bit, it's so frustrating to me that we try and get ahead of the game. We can't get ahead of the game. And not just we can't get ahead of the game, it is exponentially getting worse out there and getting much, much, much more complicated. We have to be really careful. And before we diagnose and actually what we're treating, before we start a treatment that isn't necessary, that might have only been because of a withdrawal symptom or use. So really, I hope you're all paying attention to this and understanding that it is hugely complex, but let's not put people on long-term medications that they don't need to be on. Okay. I'm sure you all, let's look at sedative hypnotics. You all have seen people under the influence. It's really interesting that people can use opiates quite a bit and not look intoxicated or under the influence at all. You throw a little Xanax in there and all of a sudden they're looking out of it or sleepy. We actually had a guy in the waiting room. They were ready to give him Narcan as an example because he's a buprenorphine client and he was like barely breathing, but he was breathing and just asleep in the waiting room after he had just walked out for a few minutes and came back in. And I said, hold on, look at his pupils. And I'll talk about this in just a minute. His pupils were not pinpoint, which would have indicated he was nodding because he used fentanyl or heroin again. They were not pinpoint. So more than likely he went out and used Xanax. We didn't give him Narcan, didn't need it. And in fact, he said he did use Xanax. So it's pretty significant. A lot of urine drug screens are coming back positive, as they have in history, opiates plus Xanax. Unfortunately, the media has not given enough attention to the Xanax piece of this epidemic and how when you add the Xanax to the opiates, you can cause death a lot quicker. During, as I mentioned, a chronic sedative use, they can look very much like depression or PDD. However, they can also, during withdrawal, they can actually have hallucinations and agitation. They can look very much like bipolar with bipolar manic with psychotic features during withdrawal, and that is not what they are. You need to treat the sedative hypnotic withdrawal and do not give the diagnosis. They might give you a history of those very symptoms, but very often in conjunction with sedative hypnotic or anxiolytic withdrawal. Now, that being said, you would see the almost identical kind of symptoms with alcohol and alcohol-related withdrawal. Okay. And protracted withdrawal, when people are finally starting to get in recovery and they're moving along and everything's going along, and all of a sudden out of nowhere they feel this intense wave of internal anxiety. You feel like you're going to explode from the inside out. It can last for a day, 2 or 3. Here's the deal. A lot of people relapse because of that feeling. The reality is we need to be teaching them how to cope with it, expect it, and it will get better. It will go away within 1 to 3 days. It's part of the protracted withdrawal or pause from benzodiazepines. It's part of it. Expect it. Learn relaxation. Call your sponsor. Go to a meeting. Realize it's going to go away. If you use the drug again, it's only going to start the clock all over again. So it's really important to educate people like this. And they go to the doctor, and the doctor sees the symptoms. Oh, you've got anxiety disorder. Oh, let's give you Xanax, Klonopin, whatever. No, worst thing you can do. You can tell I get a little passionate about this. Anyway, stimulant use disorder. Obviously, as I said, you need to put the name in. It's amphetamine type substance, cocaine use disorder. During intoxication, you can look very much like bipolar manic or hypomanic. Okay, very much like. But again, if you have the recent use of substance, you can't give the diagnosis. Please don't. During intoxication, you can also become delusional, start having hallucinations during intoxication of a stimulant, cocaine, methamphetamine. Look very bizarre. Looks like bipolar manic with psychotic features. It is not. We've got to treat the psychosis. We've got to help them through that withdrawal, not put them on medication they're going to need to be on that they think they're going to need to be on the rest of their lives because someone misdiagnosed them. During withdrawal, and I'd mentioned this before, and I said I was going to go back and forth, you can get really depressed and stay depressed. And I'm going to actually give you some slides on that, so I'm going to run through that one real quick. I'll be back to that. So you see an individual who has been using cocaine. They have a history that looks just like bipolar, because what happens is, under the influence of the actual drug, you look manic or hypomanic. You might have psychotic features. Then, very quickly, you experience a crash, which looks just like depression. Oh my gosh, of course this is bipolar, right? No, it isn't. And it's very predictable with cocaine, or less so with amphetamine, but certainly still could be. With amphetamine, you can see the psychosis. Now, with cocaine, you see the psychosis during intoxication. With amphetamine, you also see the psychosis during intoxication, but you often can see with methamphetamine and amphetamine, the psychosis go on beyond that. I've seen weeks with methamphetamine use of people feeling like worms are coming out of their skin, or seeing molecules coagulate together to form animals in the air. I mean, there are all sorts of bizarre hallucinations or actual paranoia. This is all because of the medication. You might need to treat the hallucination short term, but it's not a long-term diagnosis if treated appropriately. I'm not going to go through this. I'm just going to summarize it real quickly, and that is, you can go back and look at this. Basically, there's an initial crash after cocaine especially, and they can stay depressed, as I mentioned, for up to 2 years. Looking just like depression, maybe looking like bipolar. Reality is I would treat the depression in this case because I can treat it with an antidepressant, and actually you can reduce the risk of relapse if you decrease the suffering from the depression they feel, which is often something that pushes them back to their drug of choice, cocaine in this case. All right. So you can see, well, we've already talked about all this. I just want to mention cocaine and pregnancy fetal development. The reality is there's no strong evidence of its toxic effect on the developing fetus. I'm not advocating using cocaine, okay, during pregnancy. Do not. What I see almost routinely is those individuals who've been using cocaine, when they're pregnant, they end up having a premature delivery. I see this on a regular basis. All right, let's get into opioids a bit. So, as we've mentioned, fentanyl 50 to 100 times more potent than heroin. They've been shooting up heroin for quite a while, have a tolerance to heroin, and what happens is they don't know how much fentanyl is in there. They shoot it and they die because fentanyl is so much more potent, and they're shooting up as much substance as they thought as they had been, which would be the heroin substance. But now you got fentanyl, which is so much more potent, and boom, they stop breathing. And that's what basically happens. As I said, a little less now, because of acetylfentanyl, but still a huge problem. It's become a horrible epidemic. We say addiction hijacks the brain. Well, as I had already laid foundation for, fentanyl hijacks the mind, the body, and the soul. Okay, so the intoxication of opioids, people often can't tell when you're looking at them, if they're not nodding out, that they're actually intoxicated. Pinpoint pupils is really quite a giveaway. What I do want to mention very quickly is the locus coeruleus, an area of the brain, which is a storehouse of an adrenaline-like substance. When people have a heart attack, we give morphine, which is an opiate, and it blocks the locus coeruleus. Why? It blocks the release of that an adrenaline-like substance, which keeps the body calmer, stress-free. When the adrenaline-like substance is released, obviously blood pressure goes up, heart rate goes up, it's more stress. So it's really important to know this, because what happens is with chronic opioid use, you've chronically blocked this locus coeruleus. And when you go into withdrawal because you stop taking the opiates, you get a massive flood of this adrenaline-like substance, and that's what's responsible for the stress and panic associated with withdrawal and so many of the actual symptoms. And those are the symptoms, which you can read. Again, during withdrawal, pupils are dilated. During use, pupils are pinpoint. That's often a giveaway. Of course, you've got sniffing, yawning, goose flesh, GI upset, et cetera, et cetera. Protracted withdrawal, same kind of picture, similar kind of picture as with benzos, actually. It goes on for up to 2 years, and again, you have those periods of time where you feel this intense anxiety. Please, we're not going to treat that with opiates or benzos. No, we treat that behaviorally, CBT, relaxation, and leading up to that, motivational interviewing techniques, so they can understand and be prepared for this and implement some behavioral interventions, and it'll go away. And what happens over time is the intensity might stay the same, but over those 2 years, the frequency gets less and less and less, and eventually they don't have it anymore. But if they use during protracted withdrawal, the clock starts all over again. So one of the worst things that they can do. All right, let's quickly look at the overview. We didn't talk much about cannabis, but I did mention it with K2. You can get actually frank psychosis, more with K2 and spice than you do with marijuana. It's much more ideation, paranoid ideation. And of course, interestingly, acute psychosis is more often when eaten. And you can have generalized anxiety disorders, and once in a while you can have panic attacks during intoxication, quite often associated with paranoia. Chronic use, memory impairment, and of course, as you all know, amotivational syndrome. So as we've talked about this, during the use, you can have depression-looking, a depression-looking picture. Now, the short-acting benzos like Xanax and Ativan can cause amnesia for those events that were occurring during the time of the use. And as you get older, you can actually start losing your balance and falling. Once in a blue moon, we do see this often. We do see this once in a blue moon, not often. Benzos given, and they get extremely agitated, extremely. And it's a paradoxical effect. Don't give them more benzos. That's the bottom line on that. During withdrawal, again, we've already talked about this. During acute withdrawal, they can have Agitation, mania, looking symptoms, delirium, psychosis, and that anxiety comes and goes throughout protracted withdrawal, as I had already mentioned. Stimulants, again, in review, intoxication, you get anxiety, panic, mania, psychosis during withdrawal, prolonged depression, insomnia, and with amphetamine, more psychosis can be evident. So again, very important to understand. These few slides, by the way, are great sort of review slides of the whole presentation. Opioids, again, depressant effect, nodding out, mostly not so much. It's during the withdrawal. Again, during withdrawal, the anxiety can be a significant problem, the irritability. All right, very important when it comes to the evaluation of co-occurring disorders. Just took another sip of water. And I've been alluding to this throughout this presentation. Really understanding when the drugs are being used and when the symptoms are occurring is extremely important. So let's go through this a bit. Urine drug screening is an extremely important part of the evaluation. Well, let me just move on before I jump ahead. Okay. So if you're looking at screening, you can possibly find drugs in the system with screening. Now, screening, I'm talking about the cups that you use or the dips that you actually use at the time the individual's there. Okay. Benzos, Xanax, probably present 1 to 2 days. Diazepam, which is Valium, Librium, can be positive for weeks in reality with all its active metabolites. Marijuana, one-time, two-time use can be positive for a few days. Once you start getting into more chronic use, I've seen it positive up to 6 weeks or even longer at times. Cocaine, again, 1 to 2 days, it's usually gone. Amphetamine, 2 to 3 days, usually gone. Opioids, depending on the opioid. Now, fentanyl, it's very hard to catch fentanyl on screening. Now, there is a dip for fentanyl, a screening dip, which we use a lot, been using it for years, a couple of years now. What they ended up doing was adding norfentanyl, its breakdown product, to the actual screening dip. So even though fentanyl might not be positive because it's been 1 to 2 hours later, and that's you're not going to catch it much more than a few hours after use for fentanyl. But norfentanyl, you could actually catch up to 2 to 3 days. So if norfentanyl is positive, it's going to have, they had to use fentanyl because that's the only way you can get norfentanyl. All right. That being said, it's very important to understand that screening is not the most accurate way of determining what drugs they're using. It's very important to understand this. Actually, it can have up to a 50% false negative rate, meaning this, that the cutoff level on screening is so high it won't catch the drugs that are present because the cutoff level is so high. So it'll look negative, it'll show negative, but they still have the drug in the system, they've been using the drug. It can also yield a significant false positive rate. Screening it's more ambiguous, so it's molecular-like substances that are caught. So you might be taking a drug like Zoloft and be positive for Xanax because molecularly the body sort of sees them in a similar way, so it shows positive. So unfortunately, the rate of false positives can be quite concerning. So before you actually confront the person about the urine drug screen, especially if it has serious consequences, please be sure you know what you're talking about. I've seen babies taken away because of false positives, which is really, really, in my opinion, not the best way to do things. So screening, it's an effective therapeutic tool because if they know you're sending it off for further confirmation testing, you can say, look, we're going to send this off. We're going to know for sure. Why don't you tell us now? If they know that's going to happen every once in a while, they're going to end up being a lot more honest on screening results. And sometimes, actually, when they know that, before they even give them the drug test, we often see, hey, it's going to be positive, okay? Your screen might not be, but when you send it off, it will be. It's a phenomenal therapeutic tool, but also extremely important for our purposes in terms of knowing, well, what's going on with their symptoms. We'll start seeing bizarre symptoms going on our unit, either residential or maybe even detox. Well, drugs have gotten on the unit, and then we start seeing the reason for it because of the drug test that we have. Okay. Confirmation testing is a really great way to go because that will actually test for the presence of the actual drug. And it's got very low cutoff levels, so it pretty much, if it's there, you're going to find it there. And there's no false positives, no false negatives. There are two different types of confirmation testing: gas chromatography, mass spectrometry, which used to be the gold standard, has now been replaced. They're still very accurate. With liquid chromatography and mass spectrometry / mass spectrometry, we call it mass spectrometry tandem, very reliable and actually the only reliable testing for urine drug screening. So if you're going to confront an individual with drug use, it probably would be best to get this type of testing. And on screening, though, to be honest with you, I don't know of any false positives that show up with cocaine. If it's cocaine on urine drug testing, it's probably cocaine use. Oops, sorry, I pushed the wrong button. Okay, this is just sort of repetitive. And yeah, you're fired, Jack. Lab results came back and you tested positive for coke. Well, another story. All right, looking at key factors in evaluating dual disorders. Get the history, a comprehensive history of drug use. Get into the details of what symptoms they had during intoxication, during the actual use beyond intoxication, during withdrawal, and during post-acute withdrawal. Focus on the duration of the symptoms of each phase and the timing as it relates to potential psychiatric symptoms, okay? So, for instance, got a long history of major depression, okay? So tell me, when you use, let's say they have a long history of cocaine use. Let's look at your cocaine use. Are you depressed only when you've used cocaine at some point? Yes or no? How long does it last after you stop using cocaine? If you've had any clean time, and figure that out. Bottom line is, what you're looking for are periods of abstinence. So, all right, we know you've been depressed since you've been using cocaine. It usually occurs during withdrawal, and it goes away in time. Let's look at any period of recovery. Have you been abstinent for any period of time? Yes, I've been abstinent for 2 years. I've racked up 2 years of recovery. All right. During that 2 years, did you have any depression? Well, I started in the beginning, but no, it went away. Prior to using cocaine, did you have any history of depression? No. Well, guess what? It's probably a cocaine-induced depressive disorder. Okay? Now, in cocaine, I might use it. I might treat it. However, it's important to understand, because if I treat cocaine-induced depressive disorder, I'm going to only treat it for 1 to 2 years and start taking them off the medication, as opposed to with major depression recurrent, you might keep them on antidepressant for 3, 5 years, or even a lifetime. So it does change how long I'm going to treat and what I'm actually going to do. Benzodiazepines, same thing. When have you been anxious? Or back to cocaine, or methamphetamine, when have you been psychotic? You need to look at what the symptoms were, what the phase of use was, and then what the periods of abstinence will show you. Okay? Obviously, if they were depressed before cocaine, as an example, and continued to be depressed even after they stopped using cocaine, they've got depression you need to treat independent. And don't forget about the personality disorder issue also. So don't give a definitive diagnosis while intoxicated or withdrawing. Well, how long should one wait? I think I told you, pretty much Look at the history. Look at the entire history. Normally you can get it. Normally you can figure it out. Also, if they have a family history. If they have a family history of depression, okay, and they've been depressed during periods of abstinence for a significant period of time, plus the depression occurs when they're using drugs or not, they have a depression that needs to be treated. Psychosis, similar. If they have a history of schizophrenia and they've used amphetamine, weren't schizophrenic before, used amphetamine, now those psychotic symptoms aren't going away despite they're not using it anymore, you might have to be concerned about a schizophrenic-like picture coming up. So really get that history, the family history, get that history of what symptoms are going on during clean times. And please, those people trying to be in white knuckle it and not working on program of recovery who are alcoholics or addicts, people with substance use disorders, can be a lot of anxiety-provoking issues that come up and can look very similar to a GAD or generalized anxiety type of picture. And I've seen people who also do psychological testing. Please don't do it during withdrawal. Wait a few months, okay? Remember that the diagnosis can have a permanent ramification on what other providers do. Unfortunately, another provider might see them and just go on the diagnosis you gave. Your diagnosis is extremely important, and never question it. And they just keep I see this all the time. They keep the treatment going, but it was all substance related in the first place. So I'm making a point here. So with that, I am open for any questions. I hope that means that it was clear. Oh.
Thank you, Dr. Pomm, for your time and experience and your knowledge today and the presentation. When I conclude today's webinar, your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CE to be reported to CE Broker for Florida licensed healthcare practitioners, You must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in Florida system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The sender will be messenger@webex. Evaluation will close at midnight on April 2nd. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation.